external people that's come today from NHFT, and we're going to make a start with apologies for absence. Are there any apologies? Thank you. Members' declaration of interest. No? Superb. Thank you. I wanted to quickly mention before we move on to the agenda items, there are some key things on your desk. You'll see a document which is for the second item, item 5. There are some commercially sensitive, this is a commercially sensitive item, so please try and keep to the themes that are on this document. Okay. So on to agenda item 3. Any issues with the minutes? Oh, yes, please.
Good evening, Councillor Lawal. I just wanted to check, because you've got a commercially sensitive item, would you be wanting us to stay through that, or we leave straight after our presentation?
So we're going to discuss your item first, item 4.
Yeah.
In terms of whether you are here or you should leave, I'm going to look to Steve to comment on that.
There should be no reason for you to leave, because the stuff, what we're saying is the theme of what we're talking about is not commercially sensitive. There is data that cannot be shared, so there are questions we cannot answer, potentially, you might want to ask, that would be commercially sensitive. And so I'm Steve Oakley, Public Health Principal for Commissioning, and we'll hold the sort of, if there's a question we can't answer, I will make clear we can't answer that question in this open session, if that's okay.
Yeah, thank you. That was your question. Thank you. We're going to move on to apologies, item number 3. I wanted to make a point clear and on record that in the minutes it states that there was a report from the GP availability and appointments. It wasn't a report, it was a presentation, and it wasn't specific to GP availability and appointments, in which I want this noted so next time when it does come back, we can have a specific targeted GP and availability and appointments report. That's not on the minutes, so just wanted to make that clear on record. Thank you. Now, on to item number 4. Over to you from NHFT.
Good evening, colleagues. I'll introduce myself. I'm Linda Chibuzo. I'm Chief Nurse, Executive Director of Nursing, Allied Health Professionals and Quality at Northamptonshire Healthcare Foundation Trust. I'll ask Sarah to introduce herself as well.
Yeah. If you put your mic closer to you, Linda.
Hi everybody, I'm Sarah Mitchell. I'm the Assistant Director of Allied Health Professionals at Northamptonshire Healthcare, but also have quality within my portfolio, which is why I'm here today. You just press it once. Okay. You can take your finger off. There you go.
Thank you very much. So we've circulated our report and also provided a cover sheet for the purposes of this meeting. My apologies that we were not able to attend the previous meeting we were invited to in April, and that was merely due to our diary commitments at that time with leave and other things that came in place during that time. We're really pleased and welcome the opportunity to come here to present our report. We've not had this invitation before, so absolutely welcome having this opportunity to engage with you face to face. Our meeting is a statutory requirement, so we do have to publish the report annually in terms of our regulations under the NHS Health Act. So the report is now on our public website. However, we welcome the opportunity to come here to present it to you, to share with you our achievements for 2023-2024, the progress we made on our quality priorities, highlighting the areas we did not achieve, and our focus for 2024-2025. Whilst we're here, we also wanted to take the opportunity to then mention to yourselves that we have identified our quality priorities for 2024-2025. However, we would be able to then come and provide you an update just in year, so that if there's areas you'd like us to then focus on more, we can do that ahead of us having an opportunity to then seek your feedback at the end of the year. It just means that we're engaging with you as our stakeholders more than we've done previously, and certainly we welcome your input because the work we do is for our populations. So just a brief outline of our report. What we've done throughout the year is we had identified some areas of key quality priorities. This was a focus on improving patient care and improving patient outcomes. We've worked through those quality priorities and noted that there were some we did not fully achieve, and we would then be taking those into the following year. Some of the highlights of what we have achieved are included within the briefing sheet that we have provided, and further detail is then provided within our quality account. There were some clarifications, questions that were sent prior, which we've tried to address, and certainly we'll be happy to take further information from yourselves with regards to this, and that's why we are here. Our plan is not to go through the report page by page, but rather just a snapshot of our achievements, our areas that we'll focus on for the following year, and then we welcome your dialogue, discussion with ourselves, and any comments that you'd like to share with us and focus for the following year. So I'll hand over to Sarah, who will just give a brief outline of the areas we achieved, the areas we did not achieve, and our plans for 2024-2025. Thank you.
Thanks, Linda. Hopefully you can hear me all okay. Let me know if not. So, like Linda said, I won't read everything word for word, but hopefully pick out some of the key points, but happy to go back and answer any questions as we go if you feel like you'd need more detail. So I'm going to start with the sequin targets, so our commissioning for quality and innovation targets. The ones that we met included malnutrition screening in community hospitals, assessment and documentation of pressure ulcer risk in community hospitals, ensuring a full biopsychosocial assessment was carried out in mental health liaison services, routine outcome monitoring measurement across perinatal mental health, reducing the need for restrictive practice in CYP-MH inpatient settings, and reducing the need for restrictive practice in old adult settings. The CQC inspected our mental health inpatient acute wards and psychiatric intensive care units in August 2023, and our ratings for this service remained the same, which was overall rating of good. The number of concerns raised in the Freedom to Speak Up routes during 2023-2024 suggests a really healthy culture with regard to staff feeling able to speak up. Excuse me. Currently, the Trust has 1,580 registered nurses, with 54 qualified professional nurse advocates and 2 professional advocates who are allied health professionals. Our professional advocates provide specific additional support to our staff in leadership, professional reflections and supervision. On the 1st of January 2024, NHFT transitioned to using the nationally mandated Patient Safety Incident Response Framework, often referred to as PSIRF, for the review of patient safety incidents and events. We've appointed 3 patient safety partners and committed to involving all those who have been affected by a patient safety incident. So that includes patients, carers, next of kin and staff. We actively seek contribution to the review of incidents to understand the impact of an incident, and using a system-based approach, establishing learning and improvements that can be taken forward. In 2023-2024, 188 staff, service users, staff, relatives and carers participated in externally funded research projects approved by the Health Research Authority in NHFT, which is a significant increase to 96 from last year, from the year prior, 22-23. We've had Dragons Den projects to celebrate innovation within the organisation. We've had staff pitching innovation ideas before the panel of NHFT Dragons, as we call them. And these innovations are now being implemented, and the first set of 6-month outcomes will shortly be collated, and we hope to report that back to you as well in these future forums if we get the opportunity. We made progress on all 5 quality priorities we had for 22-23, but we will be carrying, as Linda said, some of these over to next year to further our work in these areas. So our areas for the development over the coming year include, the Trust partially achieved sequin targets. That's routine outcome monitoring across specified adult community mental health services and pressure ulcer screening in community hospitals. And despite working closely with relevant services to implement new processes and reporting mechanisms and showing significant improvement through the year, we didn't meet our required target for flu vaccinations for frontline healthcare workers, assessment and diagnosis of lower leg wounds, and routine health monitoring in children and young people's mental health services. And that the latter has been chosen as a quality priority for 24-25. And work to improve in all these areas will continue throughout 24-25. We didn't achieve the target of 0 of inappropriate out-of-area placements in adult mental health. We had 924 out-of-area placements, which is a huge improvement for 4,810 in 22-23. So this improved position is a combination of robust gatekeeping, increased efforts to repatriate patients back to their home areas, and a local contract with St Andrews to temporarily increase local bed stock. One of our quality priorities in the coming year focuses on reducing the length of stay on our inpatient units, which this should impact positively on. So the 5 quality priorities we've chosen for 24-25 are: we will deliver length of stay reductions via multi-agency discharge events, length of stay panel boards, red to green visual management system, and the development of our new step-down house. We will use quality improvement techniques to improve patient safety and experience with regards to pressure ulcer care and treatment, which is a continuation, as I mentioned before, from last year. We'll establish, implement and embed heat maps as part of the board toward oversight of the trust, quality and safety. Again, this is a carry-on from last year's priority, as there's much more work to do within this. Reduction of length of stay for patients within community inpatient services, and we'll strive for improved outcomes coverage and attainment in children and young people's mental health. So they're probably the main summary points that I'd like to raise. I don't know if we want to then move on to the questions here, or if we take those as read, or if we move on to questions from the panel here today. What do you think, Linda?
I think it's opportunity for us to then open to our colleagues to raise any comments, questions that we're happy to answer as best we can.
Yeah, thank you. Thank you for that summary. I just wanted to make a few points. Thank you first for answering those clarifications, those questions on my feedback. I note you've spelt counsellor wrong on the sheet, but I'm sure that's a minor change in the future.
Sorry for that. We'll get that rectified.
Not a problem. Okay, so we are going to be taking you through just a few themes, and I'll be opening up the floor for further questions, just to enable some structure and order to our scrutiny. My first question is, and again, I have no supplementaries to what you've already responded to. I thought you responded to them quite comprehensively. My first question is around your thematic reviews on page 72. How effective, in your view, have the 6 thematic reviews been in identifying and addressing safety issues?
Yeah, I'm happy to pick that up. So we set up thematic reviews because the whole process of investigating any safety incident is the learning that we then take away. So instead of just carrying out an investigation for the sake of doing it, which then makes it a tick box exercise, we then use what we call as thematic reviews, because we can see that this has occurred for more than 1, 2, say 5 patients. So it will be similar themes for those patients, for example, with pressure ulcers. So we did have incidents of pressure ulcers in the community. We carried out a really robust thematic review that included practitioners, families, carers, and other organizations that we work with. We feel that our thematic reviews have been really impactful and effective in us being able to learn from those incidents, as well as share learning with our staff. Some of the things that we were able to do is to ensure that we do not have a blame culture, but rather we are learning from the incident, hearing firsthand from those who are impacted, because it's really powerful when they can share their story, and that improves our learning. We had themes that we could easily pick up and address. So, for example, I'll lean into the one on pressure ulcers. So, where we noted that patients had pressure ulcers, they did have nursing colleagues going in to see them. So different staff were reviewing. However, what we then were able to identify through that process was that the reporting itself let us down. So not everyone was recording this in the same place in System 1, which then meant we had to adapt the reporting template. So as the skin bundle review is carried out, it's now in one place, which ensures that the next practitioner can see what the other practitioner has done. We also identified that patients who had those pressure ulcers really had no one managing or taking ownership of their care. So for example, with our community nursing colleagues, district nurses, it won't be the same nurse you see all the time because people do work to different patterns of work. It then meant one person has gone in and started to do something, left a note, someone else goes in. So as a result of the thematic reviews, we now have a named practitioner who is overall responsible for that care, and that's the person who reviews on a week-to-week basis, together with the clinical team coming together on a week-to-week basis to then have that robust review. We did not have that in place. Our other thematic reviews also identified themes around communication, our documentation, and that's been helpful to us as well as we've been working through our CQC must-do actions where we've now revised our care plans so that actually our risk assessments identify the needs for the patients. We care plan that, and this is co-produced with the patients, their carers, their relatives, so we wouldn't have been able to go through all that if we had not completed our thematic reviews. We also benefit from the involvement of our Integrated Care Board colleagues, our ICB quality colleagues. They sit within our patient safety group meeting. So as we were planning this, they were actively involved as well. So we were not essentially marking our own homework. So from the feedback from staff, certainly from patients, our thematic reviews have really been impactful. We can see the changes that we've made, and certainly it's a model of practice that we are carrying forward and continuing to work with.
Thank you. That follows into my next question. For about 4 of these reviews, at least on the paper, you stated on the report that a reviewer is yet to be identified. I'm just wondering what shape the review takes in terms of is it independent, what abilities and skills and competencies do you look for in the person doing or conducting the review?
I'm sorry, I missed out the first part of your question. If you could just repeat it.
Of course. So I'm looking at the who's actually doing your reviews. What abilities, skills do you are you taking forward for your reviews to be carried out? Is it done independently or is it done in-house?
So the reviews that we have completed so far for this period have been done by our colleagues who work within NHFT. And what will usually happen with these reviews is it's not going to be someone who works in that service, in that area. We look for colleagues who have the clinical skills, knowledge, and understanding of the area. Otherwise, it then becomes really difficult for the individual to understand what they're looking at, how they triangulate the information, and actually create the narrative around that. So we have investigators who carry out investigations for us. So we have a clinical investigations team who may pick up some of that work. Within our patient safety team, we've got very senior colleagues, and certainly one of the colleagues led on a thematic review. We also have other senior colleagues who work for us, and they carry out the work of investigations, and that's through our bank. So they're not actively involved within those services and actually are able to shine a lens from a different perspective in asking those confirm and challenge questions. Where we do have an issue with trying to actually find someone who's not been involved, and actually it's a very specialist area, those are the ones that we might look to. We might look to our peers in LPT to then review on our behalf, and that would be blind, so would still maintain anonymity, and they would then support us with that. But we've not had to approach them on this occasion.
Okay, thank you. What I said previously was there was at least 4 reviews that you state that have not yet been started. You've not found a reviewer for it. But thank you for your answer. Now, just specifically before I open up to other members, on your SEDS, what are the main challenges in delivering high quality care in SEDS in your children's eating disorder service?
So with regards to the Children's Eating Disorder Service, one of our main challenges that we cannot move away from is around the impacts of COVID-19 pandemic. So during that time, if you will recall, there were certain areas that were stepped back, and these were the ones that were described as non-mission critical, and that had a huge impact on us because a lot of our community services were stepped back so that we could support the inpatient services. Subsequently, waiting lists grew. We also know that with children and young people, unfortunately, they face a lot of challenges now, especially around body image, so there's been an increase in those cases in those cohorts. Unfortunately for us nationally, we've seen quite a lot of closures of children's units. So again, this puts pressure on a already small capacity that we have. So our challenges are around the long waiting list, increased challenges around the fact that there's not a lot of availability nationally. So you then find that with longer waiting, not a lot of capacity, then unfortunately it becomes a huge challenge to be able to meet the service and to meet the needs in a more timely manner. But we have put in place a process to support children, young people and families whilst they are waiting. So we've got interventions in place that support people to wait well. They still have access to other services, regular review, which may include our clinical harm reviews where indicated, and that then means that they've got oversight of clinicians whilst they're waiting.
Thank you for your answer. Thank you. Okay, we're going to move on to Councillor Buckingham.
Good evening, thank you. Looking at performance monitoring, and specifically area we wanted to look into was A&E and children and young people services. What metrics and outcomes are we reviewing often, and what do those outcomes look like? What's the forward plan? How do you review what's going on in A&E specifically, and young people and children's services?
Thank you very much for your question. So with regards to A&E, we have set targets around that. So once patients present in A&E, it's down to the acute trust to deem them medically fit to be assessed by our team. So our acute liaison team, so our mental health psychiatric liaison team, have to respond to that within 4 hours, so they need to have seen the patient. So the approach that our teams have taken is, if it's a patient that's already known to us, they do not wait, so they're more likely to go out and actually speak to the clinicians then. We then do audit with regards to meeting those timescales and patients receiving a service. So we've got that process in place already. So with regards to children and young people, I just need to understand, when you ask about matrix, what exactly are we looking for? Because it's quite a broad range of areas that we look at.
Yeah, it is absolutely huge. I think it's access for young people. I think CAMS is one of the biggest, both in acute medicine and in the community. How are we monitoring that? Because I know that some are falling off the cliff edge at 16 years old, where they're then falling into adult services and having to restart. So I think there is a great breadth of things that we could be reviewing. But can you talk us through some of the matrices you are using to ensure we're continually developing these services for young people?
Yeah, so we've already spoken about some of our long waits, so those will be monitored through that. And we've actually got targets for which we need to provide intervention. So what our teams have done, which is really, really useful, is that they're trying to ensure that patients, families do not have to go through back-to-back referral process. So once a referral is received, they are looking at it holistically to understand what other services are required, so that you're not going backwards and forwards with referrals. So for example, if we look at children, young people who are waiting an assessment for ADHD autism service, whilst that young person is waiting, if clinically indicated that they need support of the community mental health services, CAMS, that can then take place whilst they're still waiting for another assessment, whereas previously you would be waiting for one until that's completed, and then that person, that clinician refers you to the next service. So we've adapted our model so that we're not doing that. Certainly when we look at other metrics that we use to monitor performance for children and young people, within Northamptonshire Healthcare Foundation Trust, we've developed our own integrated organizational report. So our IOR, which is available on our website, because that reports into Trust Board, gives full and clear matrix for the areas that we are looking at with regards to our performance. We also rely on feedback, and certainly you will see that our feedback uptake was poor, but that is increasing now with a lot of work that we've put in from the teams who are leading the work, and having moved from a previous feedback provider to a new one, we're starting to see an increase in that. Because when we start to talk about outcomes, I think the best placed people to give us the feedback on the outcomes are those who use our services, their families and carers. So we've got a lot of focus on actually having that. The other item that we've done some work on, which we did mention from the previous year, was looking at our data and ensuring that our data is accurate. Because if our data is inaccurate, then actually whatever we report is inaccurate. Of note, we've done a lot of work in ensuring that we are collecting the patient demographic, because that will lead quite nicely into helping us address issues to do with health inequalities. So previously, that information was recorded sporadically because people recorded it in different places. Now that it's captured in one place, again, we can look at which areas access our services, which ones have more difficulty accessing it, and actually we receive feedback from children, young people, and patients. We've certainly set up various programs for children, young people, including a board that our young people sit on, and through that they are able to co-produce work with us, as well as give us much timely feedback about their experiences of using our services. We had the 2 children, young people conferences this year, and actually we had a lot of children, young people, their families, carers, system partners, sharing their stories within that. So not all a rosy picture, including challenges of access, long waits, and actually people explaining the things that they would like us to focus on so that they are receiving a service in a more timely manner.
Any follow-ups? Yeah. Thank you. Councillor Jackson.
Good evening. Targeted recruitment, retention, page 59. What specific partnerships have been established with local universities and institutions to ensure a steady supply of healthcare professionals?
Thank you very much for that question. And I'm smiling when I'm answering that, because we've been in meetings with Northampton University just in the last 2 weeks looking at our pipeline for student nurses coming into the profession. So we do have links with the university and we meet regularly with them, including the next phase of our work, which will be to look at joint posts for ourselves and the university. What we're also looking at doing is, in NHFT, we go out and do our work of speaking to students in schools and various areas. The universities also do that. So from our collective meetings, we've said, let's do it together. Let's do it once. And actually, if we can bring those teams together, then we can reach more people in that work. We also note that through our links with the university, i.e. they invite us to their functions, so the graduations, the inductions of their students, we're well invited into those, and certainly we have some of our staff going in to deliver some of those modules into the universities. With regards to NHFT and our pipeline for nurses, we've got a pipeline which is our grow our own. So where our staff have been working within the organization and they then carry out their studies through the apprenticeship route. This is a very popular route, especially for our more mature students, because it means it supports them in work and actually they are learning and moving into nursing. We then have another route that we get for nurses coming through to us, and this is not just through University of Northampton, this will be through other universities, and that's been the work that's done through Health Education England. So our relationships with the University of Northampton continue to become stronger. We are working together so that we have a steady pipeline, as well as looking at being more proactive in attracting students to come through into nursing, because we know the challenges around getting nursing students. What we've also done to ensure that once we have the students in practice, it's really important that they are supported throughout. So we've got a team for pre-registration who then support students. They also support those mentors. So the students will have their mentors, but our pre-registration team supports them. Because one of the things we know is that we do lose quite a lot of students in training and unfortunately lose others in the first year of qualifying. So we then have our post-registration team who will work with the students during that period of their preceptorship, again to give that sense of belonging, a sense of being welcome and being part of Team NHFT.
Any follow-ups? Councillor Jackson.
How effective have these partnerships been in addressing staffing shortages and retention of staff?
So we would like to believe that staffing is a wicked issue nationally. We're not an outlier to our colleagues in other trusts. And unfortunately, with the cost of living crisis, we've seen more staff choose to work for agencies that will pay them a lot more. Through our partnerships with the universities, we're pleased to say that University of Northampton are the ones who host accommodation for our internationally educated nurses and have provided this for NHFT, Kettering General Hospital, Northampton General Hospital, again demonstrating the strength in our relationships, and that's another pipeline that's become very reliable for us to get nurses coming in to work with us. We know that these interventions that we've put in place with the universities do work. However, there are factors that we will not be able to control. So some of the factors that we won't be able to control are around the cost of living. What we have put in place that really works very well, and we're seeing that coming through, is the work that we are doing now with third-year students. So we're not leaving our third-year students in limbo, having to think, where will I get a job where they've trained with us? The conversations are starting within their second year. We identify those vacancies. We work with the universities to get our own students ready for employment so that those jobs are available to them. So we feel that these interventions are working. Could we do more? Absolutely, we could do more, because this is a challenge that we face, especially when we think of our proximity, where certain areas, like just across the border into Oxfordshire, it attracts London waiting, and then certainly if you're going further afield, you've then got that London waiting. So those things will impact upon us, but we are working very hard with our university colleagues to ensure that we've got a steady pipeline, and retention is key as well.
Thank you. Thank you. Okay, on to point 4, Councillor Maxwell. On number 3. Sure, yes. What question for me ask?
Sorry?
On point 3.
Number 3, yeah, I'd just like to ask, what are the numbers of shortages that we actually have, the actual physical numbers? And are you saying that they do not pay for their accommodation while they're at university?
Thank you.
I'm just making my way to number 3.
Sorry, it's not number 3 on your sheet. This is what we're working from. Do you want to ask your question again? Did you hear the question, Linda?
Yeah, I was asked about the actual numbers, so I'm trying to understand the actual numbers of who.
In terms of staff shortages?
Yeah, I would like to know how many staff shortages do you actually have at the present moment, and that those who are on training, are you saying that whilst they're at university, they don't have to pay for their accommodation? Is that correct?
My understanding, so when it comes to our vacancies, that's a changing picture, Councillor, because it will be variable throughout. So if I'm looking at where we were with our overall staffing vacancies, I think when we ended the year, we were close to 600 whole-time equivalent. That's inclusive of clinical and non-clinical. So we have regular meetings with our NHS England colleagues with a focused piece of work around healthcare support worker vacancies, which at the last sort of check, I think there were around 150 to 154 support worker vacancies, but that is a changing picture because at each time people are being recruited, and then we also have people within the organization who progress their career, so that will always change at given times. With regards to those in training and their accommodation, we don't provide accommodation for them. It's our internationally educated colleagues, so this will be nursing, and our international medical graduates or medics who do not pay for their accommodation when they arrive, and they are going through their assessments to be registered with the professional registering bodies, NMC and GMC. And then after that, they would move into their own accommodation like all the other staff.
Thank you. I think David wants to come in on this.
So separate point, and I'm happy to wait for Councillor's time. It's more feedback on the style of the report. So I'm happy to come in at the end with that, if that's helpful.
Okay, yeah, super. Did you want any further follow-up questions, Councillor Maxwell?
Yeah, there was one follow-up actually. When you say international, do you mean people from outside the country?
That's right.
Thank you.
If I ask David to come in at this point, and then I'll come back to Councillor Maxwell for point 4. Thank you.
Okay, just the points. So thank you both for Summer and for answering a lot of those questions, and thank you to Councillor Buckingham for raising the concerns about children and young people services, because one thing which I did find about the report was that it was quite quiet on the different services that you provide to children and young people and the performance in those areas. So with my dual hat of Director of Children's Services on, you probably anticipate that I'd pick that up as well. Whilst at the start of the report you've got a link saying if you want to know more about our performance, go to our website, but for most of us it would take us hours and hours to find what we're looking for. So perhaps having somewhere at the back of the report links to particular performance reports, quarterly performance reports or something like that, might be a little bit helpful in helping us to get some of the detail. I personally found the report quite wordy, a lack of charts, graphs showing some of the performance, and I'm quite a visual person in that sense. So for those of us who don't like words and like pictures a little bit more, it would be helpful if we maybe had some of it represented in that way. It might be in the performance reports that you refer us to, but I'd have to go searching for that in that sense. Then on the section around sequins, you talk about some which were partially delivered or not delivered, but you don't say why and what are we doing about them. One of those being about reducing restrictive practice in adults and older adults, and the other being outcome monitoring for children and young people in contact with mental health services, which I think are quite important for us to understand what sort of improvement would need to happen there. And whilst I found the bit on staffing really useful, turnover is something that wasn't mentioned there, but understanding turnover and absence rates in comparison to what you expect. So you talked a lot about what you'd done and what you'd got in, but not who'd left and why they'd left and some of those reasons. So I'd find that more helpful in an annual report if that helps. So just those elements of feedback. For me, I found myself asking a lot more questions which weren't answered by the annual report. So just having links back to other areas. And whilst I know probably the majority of your 250 odd services that you do provide are in relation to adults, if we get it right for children, and understanding perhaps the areas where we're not getting it right for children will really help us to think as health scrutiny about how we support you with that, or how we work with our executive or with the Children's Trust or with the ICB through our integrated care approaches in how we commission things differently or focus on some of those agendas. Thank you, Chair.
Thank you for that, David. Those are some good recommendations. We got more later on in the meeting. Back to Councillor Maxwell, if you want to ask any further questions.
What concrete steps have been taken to foster stronger cooperation between the CIB and social care services? And 2, how is this cooperation addressing the broader determinants of health and impact GP services demands?
I'm sorry, Councillor, I didn't hear the question.
Question. Pardon? ICB, yeah. Okay. What concrete steps have been taken to foster stronger cooperation between the ICB and social care services? And how is this cooperation addressing the broad determinants of health impact that GP services demands?
Thank you for your question. I wouldn't want to start to answer on behalf of the ICB because they will have their response to the question. But I can say that there are areas that the local authorities and ICBs do work together. So when we look at our safeguarding arrangements, we do work together. And certainly when we've had ICB events, when we're looking at a framework that we would work to, this included provider organizations, the ICB, the local authorities, directors of public health. So we've had events where we've all been together face to face to work together on priorities for our populations. But certainly it's a question I could take away to ask the ICB chief nurse to then respond, because I don't want to speak on behalf of the ICB. I can only say what I know from an NHFT perspective.
I think David wants to come in on this point. Yeah.
Thank you, Chair, and I can certainly add to that. So one of the boards which I chair is the Children and Young People Partnership Board, which is part of our integrated care approaches, which involves significant contributions from colleagues over the other side of the table around how we improve the collaborative approaches within children's services. We also have a mental health collaborative, which is part of the integrated care system, which again brings together commissioners, so commissioners from the local authority, from public health, and from the ICB with providers to really address some of those agendas moving forward. Some of them are really difficult agendas and to deal with them, particularly when we're talking about some of those really complex ends of services. Those can be a bit of a challenge, so things like the Transforming Care programme, where some of our most complex people are placed outside of our area, where we're working really closely with the Trust to repatriate those people. Similarly, you'll see some reference to Tier 4 placements for children and young people in the annual report, and again that's something which is really of importance to us about trying to make sure that we are repatriating young people back into the area. Have we got it all completely right? No, we haven't. Are we restricted by some of the resources that we have in order to deliver some of the changes? Would we want to do more preventative and early help across children and adult services? Absolutely, and that's where working in partnership through those partnership boards enables us to really bring forward some of those ideas and thoughts about how we can do that differently.
Thank you, David. Yes, Councillor Maxwell.
I have a follow-up question. See, I think in the past what's happened is that not all parts of the service have actually worked together strong enough to actually meet the needs of the children. And quite often, they miss out. They don't seem to be, and where GPs come into this, well, I don't think GPs actually do come into this because personally, I think that GPs are left out altogether. I don't think they seem to find out what's going on between yourselves and what GPs can actually offer to that particular child. I just think that there needs to be more stronger collaboration between everybody to make sure the child is the person that you're concentrating on. You're not just, it's not... I meet quite a few children, and quite frankly, the parents don't think that they're getting very far with the answers that they're expecting. Thank you.
I'll let David come back to that one.
And I think certainly we've recognised that ourselves within the local system. One of the bids that we put in was around our family hubs approach, and that's something which we're trying to grow with partners to provide trusted places where families can go for advice, support to connect them into, rather than relying on something like your GP service, because that's not always the best place to go and get that support. And one of the key elements that we want to do is explore, well, how do we sustain that for the future? You will have seen similar models in the past, the Sure Start approaches, and we're really keen that we develop our family hubs model and make it as sustainable as we possibly can over the coming years, because we recognise that there is significant work to do there. I would much prefer that we're able to support people through our family hubs rather than them accessing NHFT for CAMS services, because that's too late. And we want to do that preventative work and stop people going into crisis and intervene much earlier through that network of support that we're currently developing. But again, that is not fully there at this moment in time. We've opened the one hub in Wellingborough. We've got Kettering hub being opened fairly soon, and plans for our Corby hub, but there's also an East Northants hub that we'll be working on as well. And the hubs are just the start of that. It's about growing the network and growing the knowledge and understanding about that. And we can certainly keep you informed of the progress around that.
Thanks, David. I think, Jane, you wanted to come in.
Thank you, Chair. I just wanted to give you some assurance as well, Councillor Maxwell, about the role of general practice in the planning of what goes on locally. So we have a number of general practitioners locally who are involved in lots of different levels around what are we doing as a system to get this right. So we have, for example, a GP from Lakeside locally who's really involved in lots of different areas of development across the system, including with the work with NHFT. That's really important because we need the voice of general practice in those discussions. But I do take your point that what we need as a system is more integrated approaches to how we work with young people. And I don't want to steal any of Helen's thunder, but there will be some discussion later on in the meeting about that early intervention offer and how we work in a more integrated way with things like family hubs, because what we all want as individuals is to go into a service and not ricochet around. We want to be able to think we go into a service and that support is there, regardless of which door we go into. So I wanted to give you that assurance about the strategic stuff that goes on in the system around general practice. They are very engaged and very involved, but also there's lots of work, as David has said, around how do we join things up in a way that makes sense to the person, because I think that's the most important thing. It's got to make sense to the person accessing the service.
Thanks for that, Jane. Do you want to follow up? Okay, Councillor Maxwell.
Well, what I'd like to say is I'd like to see more cooperation between schools where these children go to and yourselves and UPs. I think what happens is that I came across a little boy recently, and it seems to me that he's lost in the system. Nobody seems to be following it up exactly what's going to happen. Therefore, what happens is that he isn't going to school full time because his mother feels that there's nobody actually taking the lead. And I think that that's quite sad. And I think that if we're going to work closer together, then clearly I think we need to move forward on how close we move. Thank you.
Yeah, thank you. I think that's noted. Councillor Jenny, please, 4.5.
Good evening. I have 2 points to raise on national audits and inquiries. Firstly, what are the key findings and actions plan resulting from the national clinical audits and the confidential inquiries conducted in 23-24? And secondly, how are these findings being used to improve service delivery and patient outcomes? Thank you.
Thank you very much for your question, Councillor. So certainly we have been involved in all these, and what we do is when we come back and have findings, we carry out a gap analysis to establish where we are, where the gaps are, and then we would then put together action plans. What I'd propose to do is, if you'd agree, we can go back and actually provide this information to you so that you have it and you can review it instead of me trying to talk through the different areas. So I could actually bring that information and present it to yourselves. We can send it through electronically.
Any follow-ups, Councillor Jenny? Okay, I'm going to open up the floor to any other councillors. I'm going to ask any further questions. Councillor Buckingham.
Thank you. When you were talking about your forward look and what you were prioritising for the future, I think I heard you say about length of stay board, so monitoring how long people are staying in hospital. Obviously, that's really hard to manage as a matrix because the reason for length of stay could be pressure sores, could be no ability to move into the social care system, could be a million different reasons. How do you see that working? So will it be a thematic monitoring? And what happens after there? Will there be task and finish groups or working groups or something where you're addressing that specific issue as well as just monitoring it?
Thank you very much for your question. So internally, we do have a group that's working on this and focused on it. What we recognize is that for some patients who come into our care, the plans for the patients start far much later and they should start on admission. So having a process in place where the teams are meeting weekly to identify the needs of the patient, the destination of that patient, rather than waiting 2 weeks, 3 weeks into treatment to then come back and say, oh, we don't think they can go back home. The multidisciplinary team meet proactively, including a focused senior group who then interrogate that information around what are the blockers here, who do we need to bring in to help us to unblock these issues. And you're right, there will be those patients who would have to stay with us longer, but certainly if we are going to be monitoring this and proactive on it, then we should see less of those patients than what we have currently. So we learned from some of the issues that we had previously. When we look at some of the older people, issues around someone being frail is not necessarily rational for someone not being discharged. So we've started to change our approach with regards to that. And if we're not monitoring that length of stay, I think you'll also agree we would have people living in hospital, which is not what we want to do. We recognize that there is the work with system partners like our local authorities, especially where housing issues are indicated or identified. We've previously not been very good at this insofar as we've identified the issue, we know it's the issue, but what are we proactively doing around that issue? What options, alternatives can be put in place to free up that particular bed so that it's being used for the next person who requires it in that acute phase that they require it. So we've looked at these approaches, including the work that we've been doing with our acute colleagues on where people have been discharged and quite quickly have represented. We need to immediately pick out on that learning. So we do have monitoring that's in place, and that's done through our IT systems. I can't talk too much onto that one, but it's the relevant fields that are put in, as well as the meetings that are held weekly to then look into those issues. Because some people, it could be a deterioration, which then means we just need to revisit that date so that we're still working towards that discharge, which are areas that we were not previously very proactive on.
Jane, you wanted to come in?
Yes, Thank you, Chair. I just wanted to give a little bit of feedback in the style of David Watts, but slightly different feedback. I just wanted to say that what I found really useful in the report is the way that you say what our priority is and what this means. I really like the way that was structured. I found that really helpful. So I just wanted to give that bit of feedback. I wanted to congratulate you on some of your targets. I think the EIP, so early intervention in psychosis, to get to that level is, you know, an achievement. And I was really fascinated by your priority 5, I think it's priority 5, which is the moving ahead priority. I just wanted to point out that, you know, as a Director of Public Health, the focus on equalities and on health inequalities is really welcome. One of the pieces of work that is happening now in the ICB, which we need to link in your work on, is around the race equity framework and things that we want to take forward. And I think there's a lot of learning from NHFT to inform that. So something we'll pick up because one of my team is leading on that. So thank you.
Thanks, Jane. Is any other councillors have any questions? Further questions? Oh, yes, of course, Councillor Lawman.
Thank you. My questions will be a bit more prosaic, I'm afraid. I don't think I've ever seen a report with so many acronyms. I don't know how you keep up with them. I've got one from the covering report and the rest from the actual report. I'm just a little bit confused. In 2.3 of our report, it says that you had 924 out-of-area placements and had a target of 0 for inappropriate. So I assume that some of those 924 are, in inverted commas, appropriate. So how many did you actually have that were inappropriate?
So the reason why it's put as inappropriate is that we've committed to care closer to home. So when we place out of area, that's why it would then be classed as inappropriate. So our placements would be out of area because of bed capacity rather than the person doesn't need to be in the hospital. So we've got to report it as those being inappropriate because we do not want people placed out of area.
No, I appreciate some will be specialist provision that there is limited nationally, so some will presumably be appropriate. But so we can take it that you regard all 924 as okay. So the next one on I don't know. We've got different page numbers here, just to confuse. Page 33, or your page 15. It talks about halfway down about provision of body-worn video cameras, and obviously one of the things that I would be that we have to be concerned about is the safety of staff generally, and that's obviously for this. So, is this something that you're going to be expanding? Is it how much of a problem is it that you've had to introduce this?
Thank you for that question. So the use of body-worn cameras, we have rolled it out, and you'll appreciate that they're wholly reliant on the staff turning them on for us to pick up those incidents. So we have used them to support us to keep staff and patients safe, and we've taken quite a lot of learning from that. With regards to wider rollout, we are part of the National Mental Health, Learning Disabilities and Autism Nurse Directors Forum, and I attended the recent forum last month where actually organizations like South London and the Maudsley and other bigger mental health trusts are quite opposed to continuing body-worn cameras because the move would be having CCTV footage in communal areas, which actually means you capture that information in communal areas, which is where the body-worn cameras are used anyway. So internally, we are looking at the information because there's an evaluation that is being done nationally around them. And then from that evidence-based evaluation, we would then look at our next actions within our organization. Within NHFT, we do have a health and safety officer who reviews all those incidents with regards to staff safety incidents. So that's the officer who will review the CCTV footage where we have it, and also body-worn camera footage. And certainly there's been steps in place to support staff with regards to the reporting of these incidents, and certainly the police have been very instrumental in working with us. So that's our Operation Cavell, that we've been working with the police to stem out violence and aggression from NHS staff, and that has increased reporting awareness for our staff as well as patients. So we feel that it has a place. It does help us insofar as safety, not just for patients but also for staff. But further than that, we will be led by the national review that's taking place so that we can take a view on whether we continue a wider rollout or we start to look at the option of CCTV footage.
Mm-hmm. Now, obviously, it's a trying circumstance sometimes. On a similar vein, our page 54, your page 36, there's a whole list of prisons that you support, including, of interest to me, HMP Bedford, because are you supporting staff as well as residents, inmates, whatever you want to call them? Because there's one, a couple of years ago, one very unfortunate incident of a member of staff committing suicide who happened to be a friend of mine, so I knew, and I just wondered if the support was there for staff, because obviously I know some of the circumstances behind that.
So with regards to the prison services that we've included there, we provide healthcare services to the inmates, patients, prisoners who are in the prison. So we've got specific areas that were commissioned through NHS England to deliver our healthcare service. We do not provide wider support to HMP prison staff because that's not within our contract, and that is the responsibility of the prison governor to provide that support. But we do work with our colleagues because we are working with them, and where indicated, so for example, some of our psychologists, when there has been debriefs for our own staff, creating that psychological safe space where people can have a safe space to share concerns. Certainly our HMPIS colleagues have been part of that, so our HMP colleagues have been involved in that. But the wider remit for us to provide staff to HMP colleagues, we are not commissioned for that, and we do not provide it.
Okay. On page, well, there's two. In your introductory report, you mentioned that there are 5,500 members of staff of the NHFT, but on page 59, or your page 41, it says there are just under 1,600 of those are nurses with a few other. So I'm interested to know what the other 4,000, which is a lot of people who are not nurses, but they may be professional medical staff, but I'd be interested to know what they are.
Okay, so within NHFT, we have clinical and non-clinical staff. So we've got nursing, which is our biggest clinical workforce. Then we've got the medical workforce. We've got allied health professionals that will include occupational therapists, dietitians. It will also include speech and language therapists. We also have colleagues who work within dental services, podiatrists. They will be included within that. We've got therapists like drama therapists that we would have within the AHP cohort. We then have psychologists. We've also got pharmacy colleagues. And then more recently, we have other roles that have come in, like our advanced clinical practitioners. So those would not sit in any of those areas because they are those standalone roles. Outside of that, we've got colleagues who work within corporate services like myself. And then we've also got our estates, which is quite a big team. We've got our digital technology services. We do need our IT. That's another service we have. We then also have our catering facilities team that sits within that. So we've got quite a number of different categories of staff working across NHFT, which then make up that full number of staff and the complement of staff.
Okay. Page 66, your page 48, it talks about complaints, but there's no number of complaints received. Have you any idea how many you actually received? I mean, there's these serious incidents, but not complaints, which could be completely different.
So the number of complaints would be around, if I'm not wrong, it's between 222 to 238. I know it's within the 200 number, certainly, but I can provide the detail of that when we send the response to the other questions that we've been asked, and we can share that information.
It might be worth being in the report. Moving forward to the future priorities, page 79, your page 61, you talk about the availability of a building for step down, which is something that a number of organisations are looking at. I wondered how that's going, because it's shown to be a programme that's going to open in the near future, if not.
Could you repeat the page number, please?
Yeah, it's your page 61, top of your page 61.
I think I might have the... What's your page number that you have?
79.
79, bear with me.
Yeah, quarters 2 and 3.
So when we talk of step down, this is to support bed flow, to reduce bed flow. So it is one of the projects that we're working on currently. So this step down house is not yet officially open to my knowledge, but certainly I can come back with timeframes on that.
I mean, the comment here is that they're going to identify a building. Presumably, you have identified a building.
Yes.
Right. Only a couple more. Page 84, your page 66, there are two on that. I wondered if you could give us, there's a continued recovery to continue to address the backlog of postponed procedures, and I just wondered if you could give us some idea of the numbers involved, and also integrating electronic health records. So I just wonder where you are with EPR, because it's a problem at both our acute hospitals.
If you could just signpost me to the page number so that I know where I'm looking, please.
Your 66, our 84.
I've got to the page number, so if you could just repeat your question, that will be helpful.
So there's two. In continued recovery, there's it talks about postponed procedures and a backlog. I just wondered how significant that was. And it also talks about integrating health records, which is presumably an EPR system that is proving problematical elsewhere.
I'd have to provide you with the figures. I don't have them off the top of my head, and I don't want to guess. No. So I can provide those, certainly.
No, I think perhaps they should be. And the last question is, and I haven't got a page number for this, but there's quite a lot of comment about reducing stays in various sites, and obviously that means that a quicker discharge is one of the things. So I'm just worried about how you're identifying to make sure that these are still safe discharges, because and obviously that comes into some of the things that we do, but it's just a concern if you cut the times down to make sure that they are still safe discharges.
Yeah, so part of the work that we look at is national benchmarking around our own length of stay. And due to being an outlier in this, it then led us to then review our own processes. So the multidisciplinary team worked together, and in working together, that should include the patient, the family, the carers, to start that process of discharge from admission so that it's no surprises. So as long as we can do that together, including key partners in doing that, then actually it should be a safe discharge. I'm not saying we always get it right, but that's the ambition, and certainly for most of our discharges, that's what we've been working to.
Thank you. I want to start to bring this item to a close. Do we have any further questions on this? Thank you very much. We do have some holding recommendations, which I'll read out. In addition to what's already been stated, by colleagues. This committee requests a detailed report on the outcome and actions taken as a result of the 6 thematic reviews, with particular focus on the Mental Health Capacity Act review by January 2025. The second is this committee wants to establish a regular internal reporting schedule. It wants you to establish a regular internal reporting schedule quarterly, if not already in place, for A&E performance and health assessments rates for children and young people using agreed upon metrics and outcomes. And the third, we want you to implement a systematic approach to reviewing and acting upon findings from national audits and inquiries, with regular progress updates to the Health Scrutiny Committee. So some of this has already been touched on, but those are the 3 holding recommendations.
Thank you. Thank you. Thank you for those, Councillor. Unfortunately, Sarah and I couldn't write it or type it fast enough, so we'll ask those to be sent through to us as your recommendations, and certainly any of the other questions, if they can just be sent together, then we'll send the information across to yourselves.
Yeah, no problem at all. We'll get that sent over to you. Thank you for your time and for answering those questions. We'll now move on to item number 5. Helen.
Thank you, Chair. So I just wanted to give a bit of context to this item, just to remind everybody that public health are responsible for an enormously broad range of services, some of which we provide, some of which we commission. And this is an extremely important area of work for us at the moment, because we're in the cycle of recommissioning some of our biggest contracts. And that's what we're going to be talking about this evening. So that is our 0 to 19s and our sexual health contracts, which are really important in terms of health inequalities, but also really important in terms of, particularly with children, giving them the best possible start in life. Helen and Steve are going to present the item today. We do have a presentation, but that should still give us time for discussion as well. So without further ado, I will hand over to Helen.
It's going to be challenging because it's behind us, so we'll work from here. So if we can move on to the... you got control of it, Raj. I think Raj has got control. So in summary, we're just going to go through the commissioning arrangements that we've got in place. This is a critical point in the process. I'm trying to read on here. And that's one of the reasons why we are very aware of the timing of this and coming here, because we are very close to going live with our tender at the end of August. And that's really quite important that we are clear about what information goes into the public domain at what point, because our NHFT colleagues will be aware that we have to share with them and with the rest of the market anything at this stage because of the timing, because it could impact the process. So we're going to go through a brief overview of local needs and how that's informed the commissioning models. Helen will pick most of that up. We're going to talk about how that engagement with residents, stakeholders and the market has informed some of that model, and that's why it's in the presentation, and how those service models and the underpinning principles of those are taking this forward and helping us to sort of drive the new models into the future, as well as our commissioning activity and timeline that we've been working on and working towards to deliver a new contract in place for the 1st of April 2025. So moving on to the next slide. Commissioning of children's and young people services and sexual health services is not a simple sort of world. We deal with both ourselves, our NHS colleagues in NHS England, and other local authorities are involved currently, and in the future we still have overlap, and also our ICB. So it's not as simple as just NNC are going to commission these services. All of these services have a link into our NHS colleagues and into the ICB, as well as, for sexual health in particular, if individuals end up out of area, we have responsibility for those individuals. So when we're commissioning services, we've got to bear that in mind. The Health and Social Care Act describe what we have to do as a local council and for public health responsibility. And some of these things are a direct condition of the public health grant that we actually have to provide them, and some of them are very detailed in what has to be provided. So the Sexual Health Service, there's a national spec, and it's very clear what we have to deliver. The Healthy Child Programme is very clear also about what the mandated element of that is and what we have to do and what we can't get away from doing. We have to do those elements of it, as well as the National Child Management Programme. And this all comes through the public health grant. But all of the commissioning has got to be based upon our assessment of need in the local population, and then looking at how we meet that need in a local area, which can be very different from a more urban and a more rural community. Go on, move on. Back to me.
So just a little bit about how this slide deck's put together. So there are two sections, the first one being sexual and reproductive health before we move on to children, young people and families. There is some detail in the slides I'll go over quite quickly. There is some additional slides at the end, so I can spend a bit more time on there where you have areas of particular interest. Next slide, thanks Raj. So this is just giving an overview of sexual and reproductive health in North Northants. And in lots of areas, we're very similar to the England average. That doesn't mean that we wouldn't seek to improve, but we are very similar. What we also seek to understand is where the difference is within North Northants. What do we understand about the needs in Kettering, and how might they be similar or not similar to the needs in Corby, for example? Interesting here when you think it, because what we're doing is drawing a thread between what we understand from the data, what we've heard in our engagement, and our proposed service model. So if we think about the long-acting reversible contraception, for example, that's the method that many people would advocate because of the, it's very unlikely to fail. And equally, when we speak further on, it's about ensuring that we increase access. When we think about sexually transmitted infections, what we're seeing broadly reflects the population. So next slide, thanks Raj. So where we start to be dissimilar to England is when we start thinking about HIV. So our HIV prevalence is higher than we would see across the country. And what you might notice here is something that initially looks a bit confusing. On one point we're saying, right, okay, we're quite similar to England, but we're also saying we're a high prevalence area. That's because there's a definition of what makes you high prevalence, and that's over 2 per 1,000 people. Interesting when we think about some of the stereotypes around HIV. For us in Northants, it's heterosexual contact is the most common source of HIV, then followed by men who have sex with men. And again, that's a very specific term because it relates to how people might describe themselves in terms of sexual behaviour rather than necessarily thinking about sexual orientation. So next slide, thanks Raj. So this is the area where not only have we got some detail on these slides, I've got more slides at the end if when we get to questions you want to go back and find a bit more. So we've done a whole range of engagement. So we've done some survey work that's gone out through the council channels, so gone out to anybody. We've engaged with stakeholders, so stakeholders in service, commissioners, people working in the voluntary and community sector. And then what's on my right is that third column, is thinking about some of those groups of people who might need additional support, who are more likely to have poorer sexual health. So there we've got people who might experience stigma, we've got some of the young people. And on the bottom right hand, what we're really trying to do is link together some of this work. So Evolve is a group of young people who use substance misuse services. And again, we know that if you're somebody who's experiencing drug and alcohol issues, you're also likely to have poorer sexual health. So again, a bit more detail. So thinking about engagement with different groups in the population, and that far right hand, or at least my right hand when we're looking at backup, that's specific work that we've commissioned. So we make sure that we hear the voices of people whose voices are less often heard. And when we're thinking around black communities who've come to North Northants from areas where there's a high incidence of HIV, for example, how do we ensure that our services are tailored to meet their needs? Next slide, Raj. So this is some of the themes that are cutting across all these different groups. We need to raise awareness of sexual health services, particularly for those people I've talked to you about who are less likely to offer services. And we know that it's not one size fits all. So when we think about a digital and online offer, there are many people that will really suit. But it can't be our only service, because there are people who are digitally excluded, who are marginalised by that approach. So it's one of a number of approaches. Our services are inclusive. We no reason to think that they're not. But we do need to continue and tailor our approaches, making sure that it's not that one size fits all. Sex and relationships, I still say the old thing, relationships and sex education. That came out across a wide range of groups, that we don't have equity, across different schools, different colleges, different learning environments. So increasing that, because the right sort of relationship and sex education has a really strong evidence base in terms of supporting young people to protect themselves, to make powerful choices around contraception and reduce the risk of infection. We would need to move towards decentralising our services. So one of the slides I flashed past quite quickly is that most people who access a specialist sexual health service, so not through their GP, do so through the hub in Kettering. But what does that mean for people who want to access service in a different space? And this is where we start to think about rurality, thinking about how travel if you don't have access to your own transport, and how we can decrease some of those barriers. I've already mentioned to you there are a lot of advantages for integrating services, particularly when we think about people who might be experiencing risk-taking behaviour. And then the really important part around reducing stigma. And we do that by building trust. We do that by having a brand that people recognise. So I'm passing back to you, Steve.
Yeah, I've got it on here now. So in terms of where we're at, we're looking at a proposed model at the moment of an integrated comprehensive sexual health service. It needs to cover the whole range of sexual health services that we need to put in, that are nationally specified, things such as contraception, testing and treatment of STIs. And so Helen's already picked up on the fact that it's about building on the hub and spoke type model, increasing provision outside of that hub to those communities that can't necessarily get to the hub within Kettering for us, and obviously in the past with the county-wide service would have been Northampton and Kettering, but actually how do we get out to those individuals who can't get there themselves? Specifically enhancing the younger person service, because actually one thing we do know is your younger people who do need this service can't access it through the normal routes, and they won't access it necessarily in the same way as we think adults will, because of the stigma and the problems with getting there. Especially a young person doesn't have their own transport to get from Corby to Kettering or from anywhere they have to rely upon public transport or their parents or somebody else. So actually, how can we offer that? But how can we offer it integrated with our other services for young people? And that includes substance misuse and school health, etc. We really have to increase the digital offer. That one really does appeal to the younger people, obviously, because they're very digital savvy. But we're in a digital world and most people have got access. But we do need to be aware in doing so that it can't just be digital. It has to be wider. And making sure that where we can, that some of those digital offers include testing and treatment activity, so that you can actually start the testing and do some of that stuff. You do it digitally. Digitally, it comes to you at home and you can do it and send it in. And you don't have to go to somebody at a centre and have that testing done where it can be done. There are some things that can't be done like that. We need to support individuals that are at risk in particular and ensure they're supported to access the appropriate health assessment and then treatment if need be. But also we want to really move forward on our GP and our pharmacy input. Pharmacies and GPs are spread out across the area, and people have better access to those pharmacies and GPs. But we know that GP and pharmacy uptake of some of the services is not great. So their provision of them has reduced over time, started during COVID and has continued since. And so we want to encourage our GPs and pharmacists to take that back out. So emergency hormonal contraception for young people or anybody that needs it urgently is very, if accessible through the pharmacy, is really good and really great for those individuals. And similarly, for women needing long-acting reversible contraception, having it through the GP is quite often easier than actually coming to a central clinic in Kettering, because actually the GP is part of the local community in the main and is easily accessible on foot or by public transport if not on foot. So we've really got a lot of things we need to do, but recognising that this is a critical stage in developing that model and moving into that sort of community-based outreach. Move on to the next slide. So commissioning timelines. These are the very basics of it, and sorry, there's an awful lot of detail on there. We are at the moment coming very close to the very end of the development of the model and being able to take that model further forward. The plan is that a proposed model will be going to a market engagement event on the 18th of this month, and at which time it will, just before that event, it will be made live, it will be shared with NHFT colleagues so that that then can be informed at the provider event, but also our colleagues in NHFT will be able to inform any staff of the likely impact that that model has. And that's one of the reasons why because of where we are, we've also got to be very careful in terms of what we share at this stage with you. So that market event next week, we've been engaging with schools this week in terms of, I was on sessions this morning, and we've also got further sessions later on this week. We did secondary school today, primary school on Thursday, and then further engagement with the public before actually coming to a final model and tender at the end of August, last day in August, first day in September. I'll hand back to Helen.
So just conscious of time, making sure you've got time to answer the questions you want to. This is going to be an even swifter overview. So a bit about our demography, what do we understand about the breakdown of our local population? We're becoming more diverse. It's not as diverse as England, but becoming more diverse. We're also seeing an increase in the population as a whole. So the population of 0 to 19s, although the proportion of that age group in the population is decreasing. Now, these hand pictures on my version, I really don't know what's happened. Slightly disappointing, let's move on. So, Health Child Programme, Steve's mentioned to you. We're still some way from the England average. We've worked really hard, but there's been a real step change in the proportion of those assessments completed. And when we talk about some of the integration of services, that's the start. You know, is that child developing in line with expectations, and if not, what support can be available? I'm going to skip past some of the others, but I can come back if we have time. So a little bit more in terms of our school-age population. And again, where I say very often we're in line with the England average, when we start to look at childhood obesity, when we see the proportion of children who are obese in reception, but an increasing proportion in year 6, just because we're in line with the England average doesn't mean that that's not a focus of work for us. We know what the long-term health impacts are. Sorry, I'm not telling you when to swap slides on my Raj. I'm very sorry. I'm on the transition to adulthood step. And this is where our sexual health and our young people, where it starts to come back together. So here thinking about chlamydia detection, but also the conversation we've had earlier on around mental health. So how do we collectively have a responsibility for children and young people's mental health? Because the number of people, the proportion of young people who are admitted to hospital are a very small subset of a broader group of young people. Equally, many young people won't use drugs and alcohol in a way that means they go towards a service, but equally, we know there's risk and we know there's health harm. And how can we see that risky behaviour in context together? More information around the engagement activity. Some of this has been highly focused to make sure that we've heard the voices of children, and we've done that through colleagues who've got expertise in that area. We've heard from professionals. We've also really learnt from the engagement that's happened through the Family Hubs process. So some of it we've led ourselves, but some of it's been very integrated, because that's the model that we're working towards. You're keeping up with me, Raj, thank you. And when we look at some of these themes, I think they're unsurprising. You know, people want to have a trusting relationship. They want to know how they can access a service. They want it to be accessible at a time they want, and we get back to some of the digital offer at that point. And we know that we want to intervene at the earliest possible point in life, because that's the evidence, particularly in those 2001 critical days. And we've started to talk, and Steve will pick up on the no wrong door, that single front door. It's not something we easily achieve wherever we're working, but it's absolutely the aspiration for young people and for children and families.
So in terms of, so obviously our engagement work is really important to actually developing the commissioning model, and it gives us an idea of what parents, children and young people really want, and what professionals see the benefit of in their working day in places like schools and youth and elsewhere. So we really want to increase our focus on primary prevention. That's coming out very loud and clear in the engagement work and early intervention, as well as ensuring that early help and support is really picking up on the emerging issues and ensuring that people get help at the earliest possible point. Want to increase the support offer in North Hants through integration with the Family Hub, so that families wait less time for the support they need, but also get it in the same place. They're not bouncing around services for a long period of time. Looking to integrate those universal services for children and young people to make those pathways smoother and easier. That no wrong door is really critical. When you talk about a young person who comes into a service, they may turn up say they turn up at sexual health service, or they turn up with the school health service with the school nurse. If they get referred somewhere else, they may not turn up at that somewhere else. And that then becomes a problem, because they then continue with the problem in the community and it doesn't get solved. So what we're wanting to do is see those coming together of these services, that, especially around public health, the sexual health, substance misuse in the future, school health services, to really integrate it, but also place-based, so that the young people have got access to it locally. If we move on to the next slide, please. Oh, that's wrong. Yeah, I can do it on here, I can see it. Yeah. So again, I think a lot of this is repeating what we've said before. So it's through that engagement with professionals and children, families, school staff, etc. The models have really started to develop that sort of primary prevention, early intervention, really increase our local early help and support offer, integration, so universal, but that wrong door, we keep going back to it. So I'll move on to the next slide, I think, because it's just increasing, saying the same thing. But it's really important that in the model we're looking at, that the intensive targeted support programme for vulnerable parents and parents to be really targeted at those that really need it. A refined focus on supporting children who are picked up through the National Child Weight Management Programme, so that obesity is dealt with, so that we don't continue to see that increase from entry to school to year 6. Because actually by the time they move on from that, it's not going to go away unless it's dealt with and managed. Digital front door, we've said already, parents and families, children, young people are using digital fairly regularly. And then really focusing on the specific needs of young people, because young people do start to access services without their parents between the ages of 11 to 19. Once they go to secondary school, especially in a rural community, they're likely to be on a bus, they're likely to go to different places without their parents, and they will turn up at services. How do we help them? And making sure we also integrate that with our emotional and mental health well-being services in the new model. The problem that we won't be able to move on.
So we should be looking at the
commissioning timeline. So we've similar to the one for sexual health. Thank you. So again, similar timeline. These two services are running on pretty much exactly the same timeline. I've got 2 teams of people working on each of them, one for sexual health, one for children's. And so we're doing exactly the same thing. So as I said, we've already done the conversation with schools. We did a sexual health and we did it together, because saving schools the time of having to come to us and speak to us. We did it all on teams, and there was really good engagement with that today. and that's going to continue. And then we've got further engagement till the end of the process when we actually put the model out to tender at the end of August. So that's a whistle-stop tour.
Thank you, Steve. Thank you, Helen. You've actually answered my question, the first question. Again, we've got 5 key themes we'll be taking you through, and then I'll open up the floor to questions. But I think you answered my first question around the engagement plan. So I'll move on to theme 2 for public consultation. If you wanted to take that, Councillor Buckingham.
Thank you. Public consultation is something I'm really keen on, and I see the timelines are slightly different. You've already done quite a bit of your public engagement for your children and young people. You're still yet to do it, maybe for your sexual health. I suppose the key question here is how, I mean, looking at both of the timelines, there isn't a very big window where the public consultation ends and going out to tender. So that shaping process, how are you going to take consultation feedback and shape the service before it then goes out to tender?
Timelines are tight, absolutely. So we will go out to public consultation on the models. So that is our formal consultation around changing models. Lots of previous consultation around sexual health and children, people and families. That goes out for 30 days, and we have about a week in which we, possibly slightly longer, in which we can look at those findings, pull out the themes and think about what that might mean for how we might influence or change the model. We will try and really promote that public consultation, but what we know is that they don't always have a very high uptake. So that's why we've done so much before we've got to this point.
So just for clarity, do you mind, Chair?
Of course, yeah.
I presume the engagement has given you the qualitative information that's helped you shape what you believe the public want, and the engagement phase we're in now, the consultation phase we're in now, is more that formal, this is what we are looking to do. Okay, which makes it a quicker turnaround.
Absolutely. Well, in a sense, it's both. Because what we're doing is we're refining. So where Steve talked about the engagement with schools, it's not that schools have been excluded from any of the other parts of engagement, but some of the times we've met, we've not really focused on them as a group. So it's all that sort of test and learn and change part of it. Then we'll move into what the formal consultation, which in a sense we're not that we wouldn't seek to do it, but we are obliged to do it where we're changing service provision.
Thank you, Councillor Buckingham, and thank you, Helen. Okay, so the next question may be commercially sensitive, so I'm going to ask it, and you can answer it if you can, and if not, what is the proposed contract value of the recommissioned services? No. Yeah.
We can't give you the exact value. What we can say is it is broadly in line with the current contract values that will be known because they're published data. Having said that, of course, those contract values are currently north and west, so you wouldn't be able to just go and find it. But our usual calculation of the split of that is about 48.6% would be the north's value of that contract. So it isn't going to change significantly from what's currently in, because we don't have a public health grant that we can throw at it. So that's why it's the values is similar. And
just to add to that, for clarity, we're not seeking to make savings through the recommissioning.
Yeah, thank you for that. On to the tender, the tender responses. What criteria will be used to evaluate tender responses from service providers?
So we can't give you specifics because that will come out of the work we're doing on the final bit of the development of the service spec and the model. What I can assure you is that as a professional in procurement as well as commissioning and contracting, I am very clear that we will use the most advantageous tender. It used to be called the most economically advantageous tender. We're now moving to the term most advantageous tender, which doesn't mean it's the cheapest. It's the best mix of quality and price. That quality score will come from a combination of questions that will arise from the specification that drives us to say this is what's critical in the model. And the pricing score will be a smaller part of that, because obviously the quality of service, when you're looking at a service like sexual health and children's, is more important than how much it costs. Obviously we don't have a bottomless pit, so we normally fix the value of the tender. So we say this is the maximum value that we're going out to market for, and that would be therefore what we're seeing as being the maximum price. And then the quality would be the real main driver. Normally in things like this, we'd be looking at 80% quality and 20% on the price. But as I say, once we get to the point where we've got the model, we can then really start to give you the actual, what the criteria are that we're going to be using.
Thank you, Steve. A couple more questions and I will open up to members. Hopefully you should be able to answer these ones about your implementation timeline. So is the proposed timeline for implementation, including the contract start date of April 2025, realistic and achievable? And what potential risks or challenges have been identified that could impact this timeline?
So obviously the timelines are challenging, they are tight, but I've looked at this, I've done several of these before. They are achievable. The biggest risk in any process is the time it takes to mobilise the contract, and there are different outcomes from the tender dependent on the winning bids that we receive. Obviously, if the incumbent supplier in an HFT were to win it, I can say this because it's an if, then obviously the timelines are far more achievable because actually the staff are already employed with him, because actually it's the transition of staff from one organisation to another that takes the time and can take 3 to 6 months sometimes to do that effectively and properly. Usually 3 months is sufficient. If we have a new provider come in, that transfer can take time and there can be issues, at which point there'll be conversations with both the incumbent and the incoming supplier to make sure that we address that timeline and deliver the timeline at the best pace. There's no point saying it's going to go live on the 1st of April if the incoming supplier says, actually, we can't achieve that because we've got to chippy all the staff, and the outgoing supplier says, well, actually, we can't do it because those staff have got to have proper consultation. So our plan is fairly able, but that's one of the biggest risks is about the mobilisation. Elsewhere is obviously if there was ever a challenge to our process, which is one of the reasons why we've got to be very careful about what we share at this moment in time, because NHFT, as the incumbent, can't have information in advance of the rest of the market significantly, otherwise that could bring into law our process. We could be challenged and we'd have to restart that process. So very, very clear about that and being very careful just because of where we are in the timing of this. So that is a risk. It would delay us, but what we would to assure people is in the eventuality that we were challenged in our process, which I'm fairly confident we wouldn't be, I've run several of these before, is that what we would be doing is the discussions with NHFT is about extending the contract with them until we get through that process, because if we're challenged in the law, it puts everything in abeyance, but we have to continue to provide a service. We can't stop it tomorrow. So just because they might say, well, the process is wrong, we've still got to follow that process. So from that perspective, we're going to be working very closely with NHFT and keeping them informed of progress, but making sure we're not breaching procurement legislation in the same time.
Thank you, Steve. We've got a few more questions for later. Any members got any questions, please? Councillor Maxwell.
My first question is actually to ask you, is that what happens if parents in schools, because you said you're going into schools, is that correct?
I'm sorry, I'm not hearing you very well. You said something about parents and schools.
Yes, if you go into schools, right, and the parents do not want this, any type of provision for sexual education, how's that going to be addressed? That's the first question.
So if I take that question first then, so there has always been a legal right for parents to withdraw their children and people from sexual relationships education. Where the law changed some years ago, there are specific parts that parents can't withdraw children from, and that relates to some of the biological aspects of it. But that's not new. that's been a right of parents for a long time, decades.
So my next question is, where you're saying that children are able to access a GP without their parents' knowledge, right? That is quite difficult, actually, as it stands. But what I was interested in is that I sometimes think that you feel that children should have a right to access either the pharmacist or doctor or whatever it is. But in fact, that doesn't really happen in real life because they're now prevented even more so to get help.
So we haven't said that children and people can access a GP without their parents' consent. That isn't something we've covered. Having said that, we know from Fraser ruling Gillett competency that was set into our legal framework 80s, late 80s, early 90s, that how that works in general is, and it particularly came from accessing advice and contraception, is the first starting point is that young person going to go ahead and have sex with or without contraception? Can you persuade them to talk to parents and other significant adults? And as somebody who's worked in sexual health, that's what we would always do because that's the right thing for that young person. Do they understand the risks and the benefits of the decisions? And when you've done all of that, does in this example providing contraception, does that do more good than harm? I'm conscious that you've raised GP access a few times here. Some of what we're doing is trying to think about where else children, young people and families might access services, because what every family wants is the right person, and that might be the GP, but it also might be a community pharmacy, it might be a qualified nurse, or it might be somebody who can provide a broad range of advice and support who doesn't need to be a clinically qualified professional. So what we're trying to do is increase the offer, which will reduce some of the pressure throughout the system.
Okay, Councillor Maxwell.
Where children have an alternative education provision, right, they are more and less often not have access to this sort of provision because that type of education is done by not in schools, not deliberately governed by the school curriculum. So how is that going to be, how are you actually going to get out to these types of schools that this provision is available?
I think as a system we really recognise that children and people who are accessing alternative education are, by their nature, people who will need more of our support. So when we talk about increasing access and there being different places where children and people can access support, then alternative education is one of the things that's often on our radar. We think about some of the work that David and I do together around children who are looked after, about children where their emotional health is the reason why they're in alternative education. We want to increase the reach. So some of that might be service specific, but it also might be thinking about we've talked particularly here about relationships and sex education, but it's that PHSE banner in the broader sense. So we might be thinking about risk-taking behaviour in a much broader context. We might be thinking about substance misuse and talking to children and people, or smoking or vaping. And what we need is a whole range of professionals who feel confident to have those conversations in those settings. So some of it, and perhaps hidden a bit in the detail, is how do we provide training to those people so they do feel confident, and so they know where the limits of their knowledge are, and they have a really good understanding of where those young people might go for additional support, and if possible help them to get there.
Thank you, Councillor Maxwell. Councillor Lorman.
I can just imagine young people when they're number 39 in the queue for the GP hanging around. But actually, building on a similar thing, in the report, I think it's 4.2, it talks about accessing information at schools. I just wondered how you're going to access the growing number of homeschooled children, because they are a significant concern in some respects.
I think that's another a really important question, isn't it? Because some of the way we're talking about an approach, it is setting specific. So as an authority, we work hard to understand the number of people who are educated at home and to understand the reasons why they might be educated at home. So if we can increase our understanding of the youth and community approaches that those young people use, that might be a way we can provide additional advice and support. I'm still learning about some of the North Hants landscape. In other areas, there are sessions run for parents who are educating children and young people at home, where we might have an opportunity to talk to parents about how they feel more confident to talk about some of the issues they might perceive as sensitive. But I'd be disingenuous if I said this is something I think we've got cracked. I think we'll absolutely be a work in progress, and what you'll have seen through the paper is we've talked about being agile, we've talked about learning as we go through it. So the partner that we commission is somebody we want to help grow some of that offer with us.
I mean, from my experience, a significant number are excluded children who, but perhaps we ought to make greater use of the virtual school because and tide people in, because I'm not sure that they always know it. I did have a couple of simple questions. I'm not clear from the report whether this is being let as 4 separate contracts or one contract, and I wondered whether any thought at any stage was given whether this was something that could be done in-house.
I'm going to take the last question first. The process of decision-making, which is covered in brief at the very first part of your report, included us going through the process of saying, should we bring a service in-house? That's not usually a conversation we have around sexual health services because it's very clinical. In terms of the Children and Young People Service, the process is to understand how we might have had the right clinical governance in place, how we might have had the right and appropriate nursing leadership, and following the advice of us in public health, then the decision was that in-house was not the right provision. What we need to do is work in partnership and draw on the skills of providers who work under that NHS banner.
Can't really give you the detail of that because obviously we haven't formally put that to the provider, so to our current providers, to inform them what the impact's going to be. So that will have to come after. We can share that with you outside of this meeting. There will be 2 processes, one around sexual health and one around children's. So they are distinctly different in terms of that. So I can say that because that's actually fairly standard practice.
Because it often happens that different providers have different strengths, and some providers may come in only want 2 out of the 4, and others. So it would be important to know that at some stage.
Can I just also pick up on your question, Councillor Lorman, about providing things internally? We did a lot of work on that at the time. One of the big issues we have, particularly around young people's services, is the health visiting workforce is quite a small workforce. And nationally, there's a real recruitment problem with health visiting. They are really skilled and really valued individuals. And actually, one of the things we'd have to say is, would a health visitor working in the NHS want to be employed by a local authority? And there have been cases where people have done that and moved that workforce into that setting, but that's very difficult to do, particularly in a stretched market where there's not enough in the NHS. So we have really thought about the staffing implications. We've thought about a whole range of different issues in that internal versus external model. And I think Helen's absolutely right. The answer is working in partnership and having a really positive relationship as a commissioner with your provider. I think more and more in the system we've gone away from a thing of we are the commissioner, you are the provider, and much more of a how do we work together to get the best possible outcomes. And I think for us, that's the route we really want to go down.
Okay, thank you, Jane. Yeah, Councillor Buckingham.
Thank you. It's really interesting we touched on this point because I was thinking about it for quite some time about the balance between in-house and commissioned. And I think for me, looking to the future in a utopian world where we have more opportunity, let's suggest, actually is the commissioning part significant? And I ask that because we live in a world where all public services are on unsustainable funding. We have insecure roles for people. We have short-term planning horizons. It takes a lot of work for our staff to run the commission. It takes a lot of time for our tenderers to do the same. I love that you're saying we have a close working relationship, but should we be able to save time and funds within the commission and have as an evolutionary process of hand in hand, it might be quite good. I know we can't change that, but I think in a utopian world we should be looking for ambitious ways that we could redesign these things.
I'll bring Steve in because Steve is a procurement specialist as well as a commissioning specialist, but I think it does take a huge amount of work to commission services, and it's an enormous amount of work for the provider to feed back on things like KPIs. It's really important that we do it right so that we're not overburdening providers, but at the same time, we run on as a council, we run on the principle of best value. So it's absolutely essential. Plus, we have things that we have to report back. So within our mandated services, things like the checks for children when they're born, for example, and the checks in the first few months of life, we have to have that as part of our KPIs because we have to report that back. It's nationally reported. But I completely take your point. It's about, I think we can move all local authorities and all NHS commissioners actually would want to move to a really positive commissioner-provider model of how we actually do this going forward. But from our point of view, we are working really closely with our providers and also with thinking about how we're going to work in the future so that we get the right balance, so we aren't overly burdening, but also that we've got assurance so we can come to health scrutiny, for example, and say, we can see the key performance indicators improving, which we are seeing that. So it's really important to note that people who have been reading executive reports, for example, will see that particularly our mandated services, we've seen real progress in that, and that is real hard work on behalf of the provider, which is NHFT. We need to keep that going. It's really important, and it is that relationship that's pivotal. But I'm going to stop talking because Steve is the expert on this, Councillor Buckingham.
I suppose one of the things, answering that question about what the commissioning relationship with providers, it's something that has changed over many years. The contractual relationship is one of quite challenging. We have to challenge our providers if they're not performing. But actually the best way to get the best out in the long term is to develop a partnership arrangement whereby that provider comes on board with the direction of travel and works with us to deliver what's needed in the population. We use the health needs assessment, and that information is shared with the provider to actually develop that. We do have a best value responsibility, and going back to the procurement sort of side of this, and that best value means that we should be considering what is the best option, best provider for the money that we've got available to us. So therefore, an open competitive process does provide that. The rules around procurement are changing. Recently in January, the provider selection regime came in, and new public contract regulations will come in for the rest of the service of procurement in the autumn. But that doesn't do away with our need to secure best value. And the public provider selection regime does allow direct award to providers in certain circumstances. But the one key bit is the contract is not changing significantly from the existing contract. Our view, and checked with procurement, is that our contract's changing significantly, and therefore we do need to go through this process because the contract is going to be 50% of what it was before, there or thereabouts 48.6% of the total value, and therefore to test that out and to check that we're getting best value, but also to make sure that the model is changing, and we want to make sure that we get the right supplier for that, and that testing that out, checking it out, whilst it is challenging, will deliver the ability to say, yes, the new provider, whether it be the incumbent or a totally new provider, is the best for the council. And I will be able to come back to you and say this is best value. We will have key performance indicators. Those key performance indicators will be a short list of the things that actually are key within that contract. We have somewhere around 200 different items that are within the children's service alone that we actually receive as indicators, but we would not expect to have 200 key performance indicators, but we will still get 200 lines plus of data that informs us as to what's happening. But the key performance indicators, the things that we want to measure the trust on, or the organisation on, will be very key to that contract, and they'll be very small in number. I wouldn't want to put a number on it, but my sort of contract management training suggested 20 would be more than enough in any contract. And that's where we wouldn't want to see significantly more than that, and because actually it's in the word. The hint is there. It's a key performance indicator, and if you've got 100 of them, how can that be a key performance indicator? Even for a contract of the current contract's about across both North and West, it's about 11 to 12 million. That's even that you wouldn't want that number. You still want that sort of 20.
Thank you, Steve. Any follow-up, Councillor Buchan? Thank you. Any further questions, Councillor Maxwell?
I just got a question. If this contract, the people who are going to deliver it aren't up to what we expected, what exactly happens then?
Are we talking about after the process is completed and we've awarded? So once we go into the contract mobilisation period, we're into contractual law, and we would have a responsibility to act within that. So if the provider is not delivering in line with the contract, we would have to take contractual action in line with the contract. And there'll be very clear routes to manage that performance, both in terms of monitoring the key performance indicators and then taking action, requiring them to put in place an improvement plan, and then monitoring that over a period of weeks and months. Normally, your contract would stipulate how long they've got to before they send you an improvement plan once you've asked for it, and usually 7 to 10 days, working days that is, after you've requested it. And then if they still don't improve, there will be sanctions that we can take within the contract, and then if they still don't improve, the ultimate sanction is a termination of contract. In this kind of service-based contract, that does leave us with a conundrum, because actually we need to replace that. If we've got to replace that supplier, so it's the last, we don't really want that to happen, so working with them to make sure it doesn't happen is really key. But if we did have to, and I have had to do it, we also have to then replace them and run another process to bring in a new supplier, and you have to go through that process very independently. The provider won't want this to happen, because if you terminate a contract on breach, they have to publish it. Whenever they apply for a contract, public contract, they have to declare it. So the provider is not going to want this to happen as much as we're not going to want it to happen. So we need to work together. I have done it, but it is the last resort in the process, because you really have got to work very closely with the supplier over months and years.
Thank you, Steve. Okay, no other councillors have got questions. I've got some quick fire. Have you found, this is from your presentation, have you found there is a link with regards to self-harm, a link to social media? And you mentioned on your presentation as well about GPs and pharmacies. Can they be mandated to take up services? This is my second question. And you also mentioned about this by 2043, I think 91,000 young people in the area. How's that calculated, this increase from 85, I believe, to 91,000? Thank you.
I do have a microphone that's now not interfering with the cameras. It's a good start. In terms of self-harm, were you asking specifically around the statistic and where it comes from?
Yeah, so have you found there's a link to social media with self-harm, or is there a link there?
It's very hard to directly link one event with another, and you might anticipate me to say that from a public health point of view. When we look at the published literature, some young people will describe to us that pressures through social media, whether that's bullying, whether that's things around body image, have impacted them and self-harm. But I couldn't draw a simple correlation in there, in perhaps the way that you're asking me. And then the next one was around mandate to take up...
Yes, so GPs and pharmacies, I mean...
not at all, not at all.
Can they be mandated?
So, a GP or a pharmacy doesn't have to provide the services that we're talking about. So if we're talking about a pharmacy providing emergency hormonal contraception, what we would seek to do is engage with pharmacies, and this is work that we've done previously in previous areas, to say, look, what would be the advantage to you of providing this service to your population, and how would that funding mechanism work for you doing that? There will always be pharmacies who feel that that's not the right thing for them. There are obligations on them in terms of having a private space, for example, and talking about how they're keeping their knowledge and skills up to date. And the same thing in terms of GP practices. Often there'll be a GP who has a special interest in sexual health and will be keen to provide. The other way is to think about how groups of GP practices might work together. So if there is, if that isn't a service in one practice, how might that person access a service in another practice? And again, we've got well-established models in the region of making this work, but we have absolutely no right to make them do it.
Right. Thank you. If there's no further questions, I am going to put forward some recommendations. I've ticked two of them because you've already mentioned that you're going to be bringing these forward. But the one recommendation that this committee has is to request a comprehensive report in 6 months' time on the outcomes of all engagement activities, including how stakeholder feedback has been incorporated into the service design. Thank you. We can also send that to you if you need. Yeah. Sorry. You have to leave now?
I have to leave.
Of course. No problem. Thank you. I don't think there's any other agenda items. Thank you for answering those questions. That ends this part of the meeting. Thank you. Just on the item 6, a health scrutiny work plan.
Yeah, the next meeting of the Health Scrutiny Committee is due to be held on the 10th of September. So far on that agenda, we have 2 items, which are children's health checks and the performance of Kettering General Hospital and its rebuild. I believe Jane's also engaged currently in conversations with Kettering General Hospital regarding their annual quality account. And then also on the screen, we have some scheduled items to be scheduled, which include exclusions, family hubs, and disabled facilities grants. As always, we can take items to the Scrutiny Management Board for future consideration if members have any.
Thank you, Raj. Jane.
I just wanted some clarity, Chair, on the children's health check item. I'm not sure what that refers to. Is there something very specific that you want to know? Okay, so we can pick that up outside the meeting about what the focus of that might be. Thank you, Chair. Thanks, Raj.
No problem. Okay, that brings us to item 7, the close of the meeting. Thank you. Thank you, everyone.